Welcome everyone. We're so pleased that you all could join us for this week's lecture in Volume 2 of our 12-week No Neuropsychology Didactic series. This series brings you lectures from experts in the field covering different topics each week. This series was created by trainees and early career neuropsychologists to provide free, high-quality didactic opportunities. And we would like to thank our sponsors for their financial support of the series. Before we start, here are the disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box on the lower left of your screen, and a recording of today's lecture will be provided on our website later this week. Before I introduce our speakers today, we are also very excited about our virtual poster session, which is happening this Saturday and Sunday from 2 to 4 p.m. Eastern Standard Time on Twitter. So head over to @NoNeuropsych or search our poster hashtag, which is hashtag KN Poster Session 2020 this weekend to view a vast variety of topics from over 40 poster submissions. Now it is my pleasure to introduce Dr. Seth Margolis, Dr. Jennifer Davis, Dr. Emily Hallowell, and Kelly Sullivan for today's lecture on the neuropsychology of everyday life. Dr. Jennifer Davis is an associate professor of psychiatry at Brown University and a board-certified neuropsychologist at Rhode Island Hospital. Dr. Seth Margolis is an assistant professor of psychiatry at Brown University and is also a clinical neuropsychologist at Rhode Island Hospital. Dr. Emily Hallowell is a postdoctoral fellow in the clinical neuropsychology specialty program at Brown University based in the Providence VA Medical Center. And Kelly Sullivan is an intern in the neuropsychology track at Brown University and will be graduating with her PhD from the University of Houston later this academic year. These 4 presenters are representing the REAL Lab, which stands for Researching Everyday Activities of Living, and their talk is entitled The Neuropsychology of Everyday Life. So we are very pleased to have them all here, and I'm going to turn it over to our presenters.
All right, well, thank you so much for this opportunity to present to you all today. I'm going to be running the slideshow. I'm just gonna share the screen. Okay, can someone tell me if you guys can see that okay? All right, I'm seeing heads nod. All right, wonderful. So now let me just get this back here. All right, wonderful. Okay, so I'm Seth Margolis. I'm going to start us out today. I really appreciate everything the neuropsychology community is doing to disseminate information in these difficult times, and more especially for the opportunity to be here with you all today. So we're going to start today's discussion by characterizing what falls under the scope of everyday life for most neuropsychologists in clinical situations. First off, we're going to talk about sort of basic activities of daily living, which are just that. These are the things that we have to do day in, day out to display normal self-care behaviors. They include things like feeding, dressing, transferring from one position or station to the next at home or in the community, toileting, grooming. These things tend to be more reliant on motor activity rather than higher level cognitive activity, which is really the domain of instrumental activities of daily living that we tend to be most concerned with because they're so reliant on a higher level of complexity. These cover a large swath of behaviors or complex behaviors, but can include things like shopping, cooking, chores, money management, driving and utilizing transportation in general, and medication management. And these are considered instrumental activities because they allow us to interact effectively with our environment to make sure that our higher level needs are being met. And for today's talk, we're really going to focus mostly on the domains of finances, driving, and medications, because these are areas that we're interested in the REAL Lab and have done some work on. but also because these are some of the things that in older adults especially, which is where a lot of our focus is centered, you can start to see declines earlier and earlier as cognitive decline sets in. And that sort of dovetails with why neuropsychologists should be interested in everyday activities, why these things matter. So increasingly, neuropsychologists are asked to render opinions about, why a person's everyday functioning is seeming diminished, and really put forth an opinion about if this is due to cognitive impairment or something else. And so we as psychologists are tasked with answering why people can't do the things that they're having trouble with. Is it because the task is too hard? Is it because the environment is too demanding? Is it just that that person is too impaired? Is it some combination of those things? It's really important to embrace the responsibility that is inherent to making these sorts of opinions known, because these opinions carry consequences for things like diagnosis. So if you're going to end up diagnosing someone with a major neurocognitive disorder or dementia, you're really saying that this person's severity of cognitive deficits has crossed the threshold where now they're unable to manage their affairs independently. It could have consequences for their home environment and lead to things like a transition to a higher level of residential care, or it could lead to in-home assistance that they otherwise could not manage without. This then leads to changes in people's personal autonomy too. It could be that, more monitoring or supervision is needed to keep people safe. It could be that, they end up having limitations to their ability to be mobile in the community with driving restrictions and such. And it could even reach a level where someone has a guardian installed because they're really unable to make complex and consequential decisions about health, finances, residential matters, social matters, and other things that could have really far-reaching implications for their safety and well-being. And then, of course, helping people get better, trying to put in place rehab plans, compensatory strategies that could help promote independence and well-being. So this then begs the question, how do we, as neuropsychologists, measure everyday life? And it's important for us to kind of take a step back and sit with history for a second before we try to answer this question, because as a discipline, neuropsychology really developed out of the need to identify neuropathology. So our tests grew out of a need to detect lesions. And increasingly, technological advances in medicine have made it so that things like imaging and related technology do this task faster and better. But I don't think that that has brought our profession to its knees, because we are expanding the scope of practice and making it so that nowadays we use those same tools to predict everyday behavior, everyday functioning. But I want you guys to think about whether our tasks that were developed for other purposes actually accomplish that goal. This then raises the question of ecological validity. What is ecological validity? Technically, the definition rests on thinking that the results from a controlled experimental environment are such that they're generalizable and can relate to results that you would expect to be obtained in naturalistic environments. Now, that's a very stale sort of lab-centric view of ecological validity. For our purposes, the notion of validity here doesn't so much apply to the tests themselves as much as the inferences that we are drawing from the tests about people's behaviors. And so the practical definition that we want everyone thinking about is, what is the degree to which our tests, or people's performances on those tests rather, actually correspond to that person's real world behavior? And so how do we do this? How do we ask questions about someone's real world behavior? Typically, we're going to ask people, hey, how you doing? So self-report is a major way in which we elicit information about instrumental activities of daily living. Collateral input, or someone who accompanies the person to the interview, or someone who you talk to on the phone after the fact is another way. And clinician ratings, so allied health professionals like occupational therapists may rate how they expect someone would manage independently. But there are all sorts of issues that go along with whether or not these are good ways of gathering information that we'll talk about. There's also rating scales that you can have people fill out that are a little bit more operationalized. And the advantages to these things are that they're easy to administer, easy to score, they're very low cost. But the disadvantages are potentially more numerous. They're limited. Sometimes people have unawareness. They have a deficit that makes it so that they don't remember what they don't remember. They don't remember the consequences that they're experiencing day to day. They may deny that there are even functional consequences to their deficits. It could be that some people, even loved ones or collaterals or a very loyal physician, may be biased by social desirability and want to tell you what they think you want to hear. It could be that other non-cognitive factors like low mood or high stress are playing a role in how someone reports on their everyday behavior. And in some cases, there could be ulterior motives. It could be that someone doesn't want to out their loved one because they think that might have negative implications for their own life. And the reverse can be true. It could be the case that they want to over-endorse the degree of impairment because maybe they could benefit from that person no longer living in their home, or no longer relying on them for certain things, or having to pay for certain things to keep them independent longer. So there are lots of things to think about when doing our typical interviews or typical review of scales in this regard. And so we're neuropsychologists and we like giving tests, but it also raises the question of whether our performance-based assessments are actually better or provide incremental value. And so there are a couple features to keep in mind when we think about the value of neuropsychology in answering questions of an ecological nature. One of these features is this concept of veridicality. So this is the extent to which our standard neuropsychological tests, so the typical tools in your toolbox, how well those test performances relate to measured performance on real world tasks. This is a question of criterion validity. Can we predict someone's actual outcome behavior on the basis of our known tests? Then there's also the concept of verisimilitude that some tests subscribe to. And this is really the degree to which a task's demands reflect the actual demands imposed on the person by the real world environment. And so tests that are high in verisimilitude have high face validity. They kind of look like the behavior that you would expect someone to demonstrate in their everyday life. Now, it's not necessarily required that tests that look the way that you would expect the everyday behavior to look should also demonstrate veridicality. It doesn't mean that they're going to actually predict the everyday behavior, but you would expect that they would, and you would like that they would. And we're going to talk a little bit about that as we continue today. There are problems with performance-based tests that everyone needs to be aware of, though. So the same properties of the testing environment that serve to give us a valid snapshot of a person's neuropsychological functioning may actually confound our ability to draw inferences about the ecological implications of these behaviors. For example, a standard neuropsychological assessment scenario is going to try our best to elicit that person's best performance. We want to see as much as they can do. We do this by sampling behavior in a snapshot manner, by administering one task at a time, artificially reducing distractions in that safe environment, providing one-on-one instruction on tasks given, prompts that are supportive when needed and appropriate. Okay, and contrary to popular belief, real life is not as accommodating as a neuropsychological evaluation. All right, things don't happen and unfold in that same way in everyday life. Everyday life is messy. There's also non-cognitive factors that could actually make it so that we're not capturing what someone can do, right? These could be things like how stressed they are, their personality style, their beliefs, their attitudes, whether or not they have a lot of social support at home and none in your office. It also could be the case that someone is engaging in very high-level activities premorbidly, or someone's engaged in very low-level activities premorbidly. And so what implies a change in functioning could vary depending on those factors. there are task-based confounds too. So it's really important to embrace that, we're not just focused on, what the test that looks like they can do ends up behaving as in the moment. We're looking at what implication that has for what they can actually do in their life. So face validity alone does not equate to ecological validity necessarily. Also, we don't let people use compensatory strategies in a neuropsychological testing situation. And it's possible that in the moment, they may look as though they can't do something that in life, when their routine and their strategies are in place, they actually fare much better. There's also empirical confounds in how these tests and their relationships to everyday behavior are established to be aware of. So inappropriate outcomes can lead to inaccurate estimates of the relationship between a test and the real world behavior. And so in this sort of seminal review article by Chater and Schmitter-Edgecombe in 2003, the vast majority of outcomes were derived from self-report or collateral report. And so it's hard to know if the absence of relationships reflects the fact that maybe the outcome wasn't as robust as we would have liked it to be, or is it really that the relationships are indeed negligible between our tests and outcomes when that was the case in these published reports? And it may be an inconvenient truth, but we should also be aware that test relevance may vary by the population in question and the level of severity of one's symptoms. It may not be the case that all tests are going to give you an accurate reflection of that person's ability to manage complex activities in daily life, full stop. It could be the case that this is true of some people and not others, and we have to be aware of that and how these empirical studies determined who these tests are relevant for in order to apply the information to a clinical scenario. So at this point, your head's probably exploding and you're wondering, should I even be doing any of this? And we're here to tell you, yes, it's okay, keep calm, everything's fine. And part of the reason is because we and others who are like-minded are very motivated to research these kinds of questions and increasingly grow the empirical database for neuropsychologists like you to be able to answer these questions in a way that will be value added and helping your patients. And so the real lab, which we represent today, is really charged with investigating questions of ecological validity in adult populations with cognitive impairment, particularly older adults. And today we're going to walk you through research we find useful to clinicians in the areas of financial independence, driving safety, and medication management. We're going to highlight tools to keep on hand and concepts to keep in mind. And we're also going to forecast some things that are on the horizon for you all to stay tuned to. And with that, I'm going to turn it over to my colleague, Dr. Hollowell.
Thanks. Can everyone hear me okay? Okay, great. So we're going to spend the next few minutes briefly discussing the skills that are needed for financial independence and also how those can be measured and have been measured in a clinical setting. So to begin with, we want to first define what I mean by, or what the literature means by, financial independence or financial skills. And so I've sampled here a few of the tasks or a few of the abilities that financial independence can refer to. And these are things that are likely a part of all of our lives. It can be anything from simple tasks like handling cash, making a payment in a grocery store, at a restaurant, paying our bills, to more complex things like overseeing our budget or our investments, making sure that we are considering all the things we need for our taxes. And more recently, there's been an increase in focus on how financial independence looks in 2020, in the modern era, when online banking and making virtual payments is now more common than ever. So we'll be talking a little bit about that today. So why is this important? Why care about financial independence specifically? The reason that this is an area of interest to our lab and to other neuropsychologists, I hope, is that this is an area that we can detect early changes in our patients in terms of functional decline. So in samples with mild cognitive impairment and mild dementia, we can pick up on difficulties on tasks of financial independence, tasks of financial ability. And these can also be a marker of the progression from mild cognitive impairment into dementia. So it's sort of an early marker, a sign that we can keep an eye on to help make sure that our patients are getting the best care. But also it's really relevant to the patient's actual well-being. So outside of our assessment, our patients are living, breathing humans who want a roof over their head and electricity and heat and water. And so being able to manage your finances is important for maintaining autonomy, maintaining independence, and also maintaining safety and well-being, as well as protecting individuals, especially our older adult community, from abuse and exploitation that might come with alterations or deficits in terms of financial abilities. So, most neuropsychologists, I would argue, would say, yes, of course, this is important, but it can be hard to measure, and there's not a great consensus throughout the field about the best way to do so. And as Dr. Margolis was just mentioning, one of the most common ways and approaches that we have to assess financial skills is to simply ask. And that has a lot of strengths. So I don't mean to suggest that that's not a good thing to incorporate into our practice. It allows us to find out from a patient's perspective or from their collateral perspective where they're having strengths or where they're having difficulties. But we know based on the evidence base that, sorry if you can hear the wind. I think something just hit my window. Anyhow, we know that there are discrepancies between an individual's report and the report of their caregivers. And we also know through a fairly large literature base that patients have a tendency to underreport. So they might overestimate their ability. They may say that they're doing better than they are. Down at the bottom, I'll just draw your attention briefly to this table that was pulled from a paper that was recently published from our group that just highlights how what is reported to us about receiving assistance is not always consistent with what we would assume might be the case based on cognitive functioning. So what you can see here is the percent of individuals who said that they were receiving assistance among those who were tested to be cognitively normal, tested to have cognitive impairments in the range of mild cognitive impairment, and tested in the level of dementia. And surprisingly, those who were cognitively normal, almost 12% were receiving some type of assistance, whereas only about 50% of those in our dementia range reported receiving assistance. So this just highlights that, what you see is not always what you get. And for this reason, the field has turned towards doing more research in the realm of performance-based measures of financial ability. So the goal here, and what I'd like to talk with you about for the remaining few minutes that I have, is to discuss objective estimates, objective measures of financial independence, and with the goal that we want to be able to detect individuals who might be not reporting changes but might truly be having difficulty. So the first measure I'm going to talk about is one that we've studied within the real lab, and this is the NAB Bill Payment task. So this task has many advantages. It's a part of the NAB battery, which is readily available in many neuropsych clinics. And it's also fairly brief to administer, about 10 minutes. And it's a task that has good face validity. It asks folks to look at a utility bill, fill out a check, and then complete an envelope in such a way that would allow them to pay that bill correctly. And there's advantages to this in terms of having access to normative scores, which can of course tell us how someone's performing compared to where we might expect them to be. But our group also wanted to identify cut points that might be useful in distinguishing those who have cognitive impairment from those who have cognitive impairment and functional disability or difficulty. And so what you see here is just one of many data points from a paper that I would of course encourage folks to look at that was written by the group. And we identified that at a cut point of 16, we were able to distinguish between those who had just cognitive impairments or were cognitively normal from those who met criteria for dementia. So suggesting that this could be used clinically as sort of a nice measure of capturing that functional difficulty. The next measure that I'll discuss is one that's sort of a gold standard in the field and is very extensively used in the research literature to which I'm referring, which is the FCI, the Financial Capacity Instrument. This was developed at the University of Alabama, Birmingham, and the original measure uses over 100 items to assess 20 different financial tasks. They're simple and complex. And those tasks ultimately contribute to scores on these 9 domains that you can see up on the screen, as well as 2 global estimates. So the great advantage of the FBI is that it's robust and it's psychometrically very strong in terms of the research base that we have. And it's also very good at discriminating those with difficulty from those without in samples with MCI, Alzheimer's, dementia, MS, strokes, TBI. There's a vast literature there, but it takes about an hour to administer, which means it might not be the most clinic-friendly test. And so we're lucky that the group at UAB saw this and said, we're gonna try and make a change, we're gonna fix it. And they developed a brief form that focuses on just the top 4, thanks Seth, here. And it's much shorter, so it's 37 items. It takes about 15 minutes to administer. And it gives you still a nice assessment. It has excellent internal reliability, inter-rater reliability, and concurrent validity with the long form. So it's a good way, a good tool to continue consider including in your tool belt. The next measure I'll just briefly touch upon is the UCSD performance-based skills assessment, the UPSA or UPSA or UPSA, not sure what's the best pronunciation, but this is a measure that was originally developed for or among individuals with schizophrenia and schizoaffective disorders or serious mental illness. And it actually looks at lots of different aspects of everyday functioning or what would be needed to live independently, including things like communications, transportation, household chores. And one of the domains is finances. So again, this is a nice brief measure that if you were interested in getting more information, has been shown to successfully distinguish between those with and without dementia, and also has an evidence base in the Parkinson's community or population, where it was considered to be a valid measure of functioning related to cognitive ability rather than motor ability. So how your thinking is impacting your finances rather than simply not being able to write a check or things like that. One of the other strengths of this group of tasks is that it's been validated in several different forms, which means it's pretty flexible. And I've highlighted some of those to the bottom right. So there's a brief version that focuses just on communications and finances. There's a computerized version. They're developing or have developed a mobile version that could be done over the phone. And it's also been translated into multiple languages. So another potential tool to consider if you're interested in finding more information about someone's financial ability. Perfect. Lastly, I want to talk about some of the exciting new measures that are being developed and adapted, including 2 that were discussed in a paper by Woods and colleagues that are more modernized. They're, like I said, they're looking more towards the future and where we are in terms of technology. And so the simulated market task is a task that asks participants patients, to purchase items in an online store that it's set up to look like Amazon, to see how they're able to do something like that at home. Whereas the web-based evaluation of banking skills does something similar with a platform that looks like a Wells Fargo bank account. So folks are asked to log in using a username and account that they're given. They're given multiple accounts and they have to figure out how to pay certain bills and look at investments and interpret statements. And so in that way, these are potentially more face valid in terms of what day-to-day finances may look like now compared to some of these other measures. But there's more research that's needed to be done in these, extending them to different populations. But I hope, in total, you can see that there's lots of measures that are available that can give us a nice sense of these things. Very briefly, I'll just talk about some of the tests that the literature base has shown to be related to financial independence from our typical neurocognitive battery. And so things like arithmetic, our ability to conceptually think about numbers and also complete calculations. I think that one makes sense. So it wasn't one that came to my mind initially, but that's of course a foundational skill in financial independence. And then executive skills, so cognitive flexibility and being able to attend and focus and have divided attention. Those are fundamental to being able to do these tasks. And then finally, verbal memory as well has been demonstrated to be related to financial independence. So I highlight these to say if you see deficits in these areas, areas, it might be worthwhile to have that conversation, to speak with your patients about what might be going on behind the scenes. So lastly, just in sum, I hope that this encourages you to consider financial independence in your diagnostic interviews, being wary, of course, that there is going to be bias, but using that as a great resource to get information about what might be going on. Consider your neuropsychological data and when it's appropriate to follow up on financial independence, and then incorporate performance-based measures. Familiarize yourself with one or two that you feel comfortable with so that you can use those in your practice. And very lastly, I just have some things to discuss at the feedback. So, I'm not going to go through each of these, but what I want to recommend most is that someone's performance on one of these measures doesn't mean that we should automatically say, oh, you can't manage your finances anymore. Someone needs to take those over. Rather, this is going to be a way that we can identify people who may need to be monitored and identify people who may need additional assistance on a case-by-case basis. So whether or not they need additional family oversight or maybe just set up auto payment, things like that, and going up the scale of making sure that we're being mindful of where people stand on financial independence. So thank you for listening.
All right, so now we're going to switch over to driving. Go ahead and advance. All right, so, we know from epidemiological studies that older adults are increased risk for crashes at a level approaching teen drivers. We know how high risk teen drivers are when correcting for driving exposure. And when we add cognitive impairment into the mix, that makes someone even at greater risk. So cognitively impaired older adults are at even greater risk with 2 to 5 times increased risk of crash compared to age-matched controls. And this picture to the left just illustrates an older woman who crashed into one of our bakeries in town when she had pedal confusion. I'm not sure if she was cognitively impaired, but certainly had a crash. Okay. All right. And in fact, when people become increasingly unsafe with progression of cognitive deficits. So with time to driving restriction being faster in individuals diagnosed with dementia compared to MCI. So this slide illustrates a sample of drivers that we followed longitudinally over 3 years with serial road tests at 6-month intervals. And what this shows is that individuals with a clinical dementia rating of 0.5, that's that top line, the darker line, ended up having to stop driving about at 605 days, a median range of 605 days, whereas drivers with dementia or a CDR rating of 1 had a median time to stopping driving at 324 days. Okay. So one of the questions that consistently is raised in studies of everyday functioning is what outcome is the most appropriate. So in driving, the on-road test is considered the gold standard outcome for driving research, but there are limitations to that because the person's driving in a vehicle often that's unfamiliar to them. They're often in an environment that's unfamiliar. And so sometimes people feel that the road test might augment problems that are not accurate. And, family members often push back on that and say, well, they might do better in their own environment. This isn't accurate. So we set out in our clinical work in our research rather, to try to determine if how an individual drives on a road test is reflective of how they're actually doing in their home environment. So and we did this by installing cameras into people's cars after they passed a road test and monitored them for 2 weeks continuously. So we just recorded what happened and how they drove in their neighborhood. And what we found is that compared to healthy controls, cognitively impaired drivers made more errors on both a road test and in their own environment. And the cognitively impaired drivers were also at greater risk for crashes and we followed them for a year. And then if you see to the left, the table shows by order of severity what kinds of problems people were showing when they were driving in the naturalistic environment. And the circled ones indicate where there was overlap between the road test and the home driving. So they weren't perfectly identical in terms of what happened, but there was certainly overlap that helps kind of add validity to the road test method. So, you know, in terms of a take-home message, although environment is important, you know, driving performance does not simply normalize when the individual is evaluated in their typical environment and routine. Okay, so the research I just discussed demonstrates that we can identify errors in a person's environment and confirms why older adults may be at greater risk for crash. But the next natural question for us was whether or not we could actually intervene to improve driving and maintain functional independence. So really impacting that daily living skill. So to do this, we again installed cameras in individuals' cars, but this time we used a G-force triggered technology. A G-force trigger technology that captured events as they happened. And so this graph illustrates on the x-axis the number of safety events that were occurring, and on the y-axis the different types of events that people were engaging in. The blue line reflects the errors that people were making during baseline monitoring over 3 months, and the red line reflects the number of events that occurred while they were receiving feedback. So what we did is we communicated with the family member and the driver through telehealth, essentially, and discussed with them the kinds of errors they were making, and then gave them feedback on what they could do instead. And what the study showed is that we were able, in this open trial, to significantly reduce the number of safety events that were occurring just by giving them feedback and tips on how to change their behavior. And we were able to replicate this finding in a controlled trial where we compared the individuals, compared people who received feedback to those who did not, but were still being monitored, and that paper will be coming out in a couple months. Okay. All right, so that's great. You know, I love using cameras, putting them in cars, it's excellent, and I get a lot of great information, but it's obviously not practical. So we need to think about in-clinic ways to understand how someone might be driving and what that risk might look like. So one very simple and practical and cheap method is collateral report. So if someone is with the person, they're observing that individual in the same way that I might be observing them with a camera in their car. So what we did is we evaluated the accuracy of family report of driving, and they were both spouse or adult family members, with road test performance and naturalistic driving performance. And the findings were interesting. So spousal ratings were unrelated to the road test, and they were actually inversely related to naturalistic driving. So this means that the spouse described the individual as driving better in relation to actually poorer ratings by the instructor. So not only were they inaccurate, they're wildly inaccurate. Now, when we look at adult child ratings, their pattern was different. So adult children ratings were related to performance on the road test, but not with naturalistic driving. So there was a little better signal, at least, coming from the adult children. And this was even despite the fact that adult children spent less time with the driver. So this, causes you to think about who you're getting information from and understanding who that collateral might be. And as Dr. Margolis said, what could be our ulterior motives? Spouses may be dependent sometimes on each other for driving. Okay. All right, so then let's shift to neuropsychological measures. This is what we're all doing. And we need to understand, how cognitive measures may predict driving ability. And there's been a lot of effort put into that. Okay, come forward. And what I'd like to focus on are widely used neuropsychological measures that are mostly in our own toolboxes, and we use them every day, and ones that have really received attention in the driving literature. So the first is the clock. So the clock, I published a paper that's with this title with Dr. Manning, and the pros of the clock, of course, are that it's brief, and it's easy to score, and it is sensitive to cognitive impairment. And it's actually been recommended by organizations as a good screening measure for driving impairment with the Freund scoring method. But that's actually based on very little data. So we wanted to challenge that. So we looked at 3 different scoring methods, and in our data, the clock drawing test was correlated at a pretty high level with road test errors at a 0.76 to 0.85 level, depending on the type of scoring system used. But unfortunately, when we actually looked at its discriminant sensitivity and specificity, we were misclassifying drivers at 76% of the time in terms of safe, marginal versus unsafe categories. So certainly a strong relationship with driving, but becomes difficult to categorize safe and unsafe drivers. And if you look here, you may see why. So if we, here's a sample clocks from our group, and then if you look at their driving ratings, which appear below, certainly the fail category is fairly obvious. Those are pretty horrendous clocks. But if you look at this group of pass and marginal, they become harder to discriminate. And that unfortunately is the place we want to be, right? As neuropsychologists in an outpatient clinic, we're mostly wanting to identify those people who are just emerging with problems in ADLs. And so it's a little more difficult to do this with the clock. Okay. So then the trail making test, another favorite of all of us. So we looked at trail making in a very large group of drivers, over 300 individuals. We were not looking at demographically corrected performance scores. And we really looked at validating what we were finding in a different sample. So we had a Rhode Island sample, then we validated our findings in a separate Missouri sample. And we found very stable results with cut scores of 48 seconds for trail making part A and greater than 108 seconds for trail making part B at doing a good job identifying unsafe drivers based on a road test performance. So that again gives you at least a little bit of a cut point, an indicator if you're getting this in the clinic that this might raise a red flag that someone may be having trouble with driving. One step back here, let's look more broadly. So this was a meta-analysis done by Rieger in 2004. So looking across constructs of cognition. So put, mental status, attention, visual, spatial, memory, executive, and language. And I'll call your attention to, if you want to forward, Seth, call your attention to the black bars, and that is the road test. And you'll see here, the strongest correlation was with the road test with attention and visual spatial measures. The non-road category here reflects simulator, and that's a whole topic that I won't touch today. There are quite a few relationships with simulator performance, but we need to remember that a simulator is a really, really fancy cognitive test. And so we may be seeing stronger relationships here because it's test-to-test relationships rather than truly cognitive measure to driving ability. And this also confirms, caregivers or informants are not doing a very good job. Okay. All right. And then if we just up the ante a little bit and say, well, who's going to get in a car accident? The MARIPODS data set is a great place to look at that because they've been following older drivers for a long time. And if we look at the baseline odds ratio, what this is looking at how the odds ratio basically indicates how much more likely a driver who fails a road test will end up having a crash. And what this shows here is that when they look at data a year retrospective to the crash plus a mean 20 months interval afterwards, there's a very high odds ratio for visual perception tests and trail making part B. So again, both of those constructs being fairly strongly associated with driving ability. All right, so then we know those are our traditional measures. They're in all of our toolboxes. Let's think about some newer measures, the NAB driving scenes, not that new, but thinking about measures that are more face valid. And what does that do for us? Does that bias anything? So for those who aren't familiar with the NAB driving scenes, they're these images of different scenarios that the person is viewing as if they're behind the wheel. And they're looking at those scenes for 30 seconds, and then they're shown a new scene, and they're asked to say, what is different or missing. And when we look at drivers with mild dementia compared to healthy controls, the mild dementia patients perform more poorly on this task. Great, it's a good measure of cognitive impairment. And then importantly, when we look at these driving scenes as they relate to the road test, there was a nice correlation with the road test and global ratings of safety. So there was a strong relationship with that performance, with those rated safe scoring better on the NAB than those rated marginal or unsafe. Again, as I've talked about before, however, we had trouble discriminating between that marginal group. Those are always hard to really identify appropriately. So again, this is another tool, though, that may be appropriate to have in your clinical battery, giving us some information about potential driving ability. But remember, face validity is not equal to functional ability. All right. So then when we think about, I'll just kind of go through this quickly, there is a consensus statement about driving that would be important for you to read as you're thinking about this. And these are different issues that you may want to be gathering in your clinical interview, like how much they're driving, or if they've had a history of crashes. But if we want to advance one more, I'll call to a point that they say there's insufficient evidence to support or refute the benefit of neuropsychological testing. So again, be aware that that consensus statement is out there. So if we move forward, I would consider that the best predictive model that we can use are going to be a combination of pieces of information from the history, the cognitive evaluation, and informant report. And I would recommend using the AAN driving questionnaire as a good questionnaire in your clinic. Obtain collateral from multiple sources. Consider driving reserve, so if someone is a professional driving instructor or a professional driver, they might be able to drive longer and tolerate cognitive impairment. And just remember that our cognitive test should not be the sole determinant of taking someone off the road. And then I'll close with just at the feedback, thinking about other recommendations, recommending a road test, consider family monitoring, asking the patient to maybe change their behavior some to when and how they drive, and lay out a plan for eventual cessation if that's where you're headed. That should be a gradual plan, and provide resources to support the family in that process. Okay, and I'll end there.
All right, and so the last everyday activity that we're going to talk about is medication management. So we know that prescription drug use increases with age, such that 85% of older adults take at least one prescription medication and 35% take at least 5 prescriptions. And that's not even counting over-the-counter medications or supplements. And we all know that severe cognitive deficits can be, like those seen in dementia, can interfere with medication management, but even very mild cognitive deficits can also cause some problems. And there's a few ways that medication management can be related to cognitive impairment. So on one hand, cognitive impairment can increase the risk of making medication errors. And in turn, missing doses can lead to poor disease management, or taking extra doses could lead to toxicity, both of which can increase the risk of developing or worsening cognitive impairment. And just some terminology, when we talk about medication management, that's really referring to capacity. So that's usually what we're measuring in the lab or in the clinic. It includes what someone is able to do under the best circumstances. And medication management includes a lot of different skills. So abilities necessary to store, refill, remember how, when, and whether medications have been taken. And that includes not only oral medications, but also like monitoring blood sugar and administering insulin and diabetes. So there's a lot of different skills involved. While medication adherence refers more to what someone is actually doing in their day-to-day life. And it's important to remember, as we've been talking about throughout this presentation, that just because someone gets a low score in your office doesn't necessarily mean that they can't do well at home, and vice versa, since the environments are so different. But that being said, there are multiple tools we have that can be useful in predicting medication adherence. And there's multiple cognitive domains that are relevant. I just put some of the most important ones here. So retrospective memory is what we usually think about when we think about memory, remembering information that we've learned. So that would include like information about how to take your medications, remembering what you're supposed to do. And both verbal and visual memory are relevant to medication management. And then prospective memory is that ability to remember. So when you're going throughout your day, do you actually remember to take your medication at the time that you're supposed to? This is something that's really relevant to medication management, but that we don't tend to measure as often as neuropsychologists. Another really important domain is executive functions, since medication management requires a lot of planning and organization, and deficits in attention and processing speed can also lead to medication errors. And so my colleagues conducted a study in a clinical sample of older adults and categorized participants as independent or assisted with medication management. And results showed that those who are independent in medication management perform significantly better across all measured neurocognitive domains. But when all the domains were included together in a regression, only executive functions uniquely predicted independence in medication management. So executive functions seem to be the most important in this study. And one reason that executive functions may be related to medication management is that these higher level organizational skills may help with learning a medication regimen. And of course, there's a lot of other relevant factors besides cognition that can influence medication adherence, including someone's personal beliefs about medications, health literacy, regimen complexity, symptom severity, and psychiatric factors as well. And in terms of measuring medication adherence, there are a lot of self-report scales out there, including some scales that are specifically geared towards assessing medication adherence, and then other more general IADL questionnaires that include some items about medications. And so this is just a small sample of the different scales that are out there. As we've mentioned, these can provide valuable information very quickly and cost effectively, but they can tend to overestimate medication adherence. There's also a variety of performance-based measures of medication management out there, some which require participants to put fake pills into a pill box or measuring different aspects of medication management. And the measure that our lab has studied and used the most is the MMAA, the Medication Management Ability Assessment. So the MMAA requires the patient to role play how to take 4 mock prescription medications, and there is a 60-minute delayed recall component. And the MMAA correlates with other measures of medication management and has demonstrated validity in a wide range of clinical populations. And in particular, the studies listed here in patients with epilepsy by Dr. Margolis, and the study in amnestic mild cognitive impairment by Sumita and colleagues showed that performance on the MMAA provided useful information about medication adherence above and beyond what information was provided from self-report measures. However, none of these studies looked at patients with dementia. So my colleagues looked at the MMAA in a clinical sample of older adults who underwent neuropsychological assessment and were classified as cognitively normal, MCI, or dementia. And you can see that performance on this task differed based on clinical diagnosis. And in particular, the MMAA seemed useful as a diagnostic tool to differentiate those who have dementia from those who do not. And a cutoff score of 23 on the MMAA had strong sensitivity and specificity for identifying patients with dementia. And in a couple studies from our lab, the MMAA has also shown ecological validity in distinguishing those who are independent in managing their medications versus those who receive some assistance or were dependent on others. And in a logistic regression, worse scores on the MMAA predicted requiring assistance with medication management, even after controlling for executive functions. So this suggests that both our traditional neuropsychological tests and performance-based measures of medication management can provide complementary utility in identifying people who might have trouble managing their medications. There's also some more naturalistic ways of assessing medication adherence. Of course, direct observation may be the most accurate, but it's probably not practical or feasible in most situations, or desirable even. But we can do some other things like pill counts or looking at pharmacy refill records, which can give kind of a proxy of how often someone is taking their medications. In some circumstances, lab testing can provide useful information, either about the level of disease markers in someone's system or the actual blood level of the medication. Electronic monitoring of pill-taking behavior can also be done, such as with MEMS caps. And MEMS refers to the medication event monitoring system. These are basically special pill bottles that electronically record every time the pill bottle is opened. And this is a useful research tool to provide information about when someone is actually taking their medications. And of course, we're doing a lot more online these days. And there is some research out there looking at online pharmacy navigation and the ability to refill prescriptions online using the TOPS, Test of Online Pharmacy Skills, which found that these studies found that a variety of neurocognitive functions were relevant to online pharmacy navigation. So what can we do clinically? Well, in addition to asking about medications in the clinical interview, it's important to look at performance on traditional neuropsychological measures, particularly in the domains of executive functions and retrospective and prospective memory. And in terms of performance-based measures, we favor using the MMAA because of its evidence of ecological validity and also just its feasibility. The test does allow patients to take up to 15 minutes, but we found that it usually only takes about 6 minutes on average. So that's something that could be easy to add to your clinical battery, especially if you're seeing older adults and you're getting some conflicting information or there's some question about their ability to manage their medications. And then if you have suspicions that someone might have difficulty with their medications, what can you recommend? If they're really impaired, they're probably going to need some type of assistance from others. But even people with just mild impairments might benefit from some strategies like establishing routines, using some kind of system to track their medications, alarms. They can have their prescriptions put into blister packs. And there's actually all kinds of smart pill boxes available now with built-in lights, alarms, or locks, kind of integrating multiple strategies in one. And we found that people with the amnestic form of MCI reported using fewer strategies than those with non-amnestic MCI. So these may be the patients that are most in need of some recommendations and help in managing their medications at home. And just to give you a sense of what's on the horizon, we're currently conducting a study of older adults with MCI, giving them a variety of neuropsychological, psychosocial, and self-report assessments, also doing medication monitoring with the MEMS for 2 months, as well as pre and post pill counts. And then we're providing participants with feedback about their medication adherence. And I recently received a seed grant to conduct follow-up interviews with these participants after they complete the study to get some more information about their use of compensatory strategies at home and whether they spontaneously made any changes to how they manage their medications after we gave them that feedback about their MEMS adherence. So we hope to have more in this area to share with you soon.
Great. So now I'm going to talk just a little bit more about the future of assessment. There's a lot of stuff that's been done and is on the horizon. The paradigm of virtual reality is something that is increasingly researched and may prove relevant to our clinical needs in the future. This is one example. The virtual action planning supermarket was one paradigm that was useful in demonstrating that patients with mild cognitive impairment navigated a supermarket much less efficiently than healthy peers. And so you could imagine that there are so many different permutations that could grow out of how we can sort of transport someone to everyday environments in a simulated way via virtual reality without necessarily building a supermarket in our clinics, which is obviously quite unfeasible. Technology also may change some of what you learned about today in terms of potential cognitive predictors of driving fitness. You know, if Elon Musk has his way and there's self-driving cars, who knows what that's going to mean in terms of drawing inferences about whether someone can, you know, stay safe on the road with cognitive impairment or not. Other features inherent to advanced driver assistance systems like automatic parking, automatic navigation, emergency driver assistance, and collision avoidance systems will also potentially have implications for who can and cannot be considered safe to stay on the road. There are also alternatives to MEMS that are on the horizon. Our colleague Catherine Sumida at Washington State University is doing great work with the Estimote stickers, which are, you probably all heard of wearable technology. These are nearables. These are essentially motion sensors that can be affixed to a lot of different sort of systems like pillboxes in this case, and then give you real-time information about how much patients are interacting with those systems in their day-to-day life. So stay tuned. The folks at Washington State University are also doing really interesting things in terms of monitoring people in their homes using smart home technology. And I would encourage everyone to tune in to Maureen Schmitter-Edgecombe's work, as her lab is really on the forefront of this interesting and very important work. And they even have smart home technology in a box that could be sent to patients to turn anyone's home into a quote unquote smart home. So definitely tune into their wonderful work. In the meantime, you know, we have to deal with what we have at our disposal. And so we hope that you're taking away from today's talk the fact that cognitive tests, both the standard ones that we were all brought up on and consider our bread and butter, as well as these performance-based simulations that we've demonstrated for you today, they have clinical utility. And we would argue even ecological validity in some respects. But that combining those tests with self-ratings, collateral input, and the impressions held by you know, knowledgeable clinician informants are really going to pave the way for informing your clinical decisions. And so we hope that people are taking away the notion that you can have confidence in you know, making recommendations to further people's workup and recommend things like additional sort of testing, whether that be a road test or maybe having a nurse or a social worker go into the home and see how things are doing. Maybe tailoring strategies for individuals to help them work around their presumed difficulties or the difficulties that have been described by knowledgeable informants in your presence to help promote their independence and help them age in place for as long as possible. Plus, increasing monitoring when appropriate. You know, it may be the case that people just need a second set of eyes, maybe not to take things over, but just to make sure that they're staying safe and not getting themselves into increasingly risky situations, as well as then eventually implementing assistance as appropriate so that they're not left to their own devices when we think that that could be perilous for those individuals. And then ultimately knowing that there will be a time where it's appropriate to recommend cessation of independence in any or all of the spheres discussed today, because the person either doesn't have sufficient support or even that additional you know, surrogate support won't be enough to make sure that they can manage independently any longer. We'd like to thank our collaborators and our research assistants for the wonderful work that they do in helping to grow the empirical base for all of this work for the betterment of our profession and our patients. We'd like to thank especially the participants of our research studies for giving of their time and their valuable effort to help inform the science around these sorts of questions so that we can more and more have confidence in the work that we're doing and the implications of that work for promoting independence in patients' everyday life. And we especially would like to thank all of you for your attention and interest, and we are open to any and all questions at this time.
Thank you all so much. That was such a lovely presentation, definitely an in-depth view of this area. We did have a couple of questions. We'll just take a couple of minutes of your time. The speakers agreed to be around for a couple minutes after the presentation. So we'll just hit some of the high point questions and go from there. First question is related to driving. So this attendee says that in New York, we cannot make make reports to take away licenses. What are your thoughts about our role as neuropsychologists and the process of reporting drivers? Do you feel that there's a path for advocacy to request that privilege for psychologists?
Thank you for the question. I don't. You know, I think as someone who, many of you may have had to deal with this with patients, it's a really challenging process. And I think our role is very much communicating with family and the patient and the practitioner and communicating very good information to them, and maybe work in collaboration with them. But I think I don't think it's a necessary role for us. I feel like we can still be involved and support this process, but don't necessarily need to have that specific role.
All right. This next question is related to driving as well. So how can we predict cognitive performance related to driving fitness due to the progression of dementia? So perhaps is it necessary to do repeated practical driving tests over time?
Yes, and that would really, that kind of recommendation came out of some of our longitudinal work, in that we really need to reevaluate people on about a 6-month basis is really the recommendation to capture, you know, when it is that somebody might need to come off the road, but that's not always going to be practical. So if possible, yes, repeated road tests, but it becomes very, very challenging to get that done. I think in other ways it can be done through more frequent monitoring of kind of global cognition in the primary care office, with making sure collaterals are involved, and then these other kind of situations where family is monitoring, acting as a co-pilot, kind of watching for errors. There's the AAA and the Hartford have some good checklists about the kinds of errors family are looking for, because it's just very difficult to kind of pinpoint when is it really time to come off the road.
Right, that's a good point. And actually, speaking of references and resources, we had a couple of requests in the Q&A for a reference list that we might be able to attach to your presentation on our website. So if that's something that we can pull together from the slides, that would be wonderful, because we had a few requests and we would like to be able to highlight your work and the others that you provided.
We can do that.
Well, that's, oh, go ahead.
I was just saying we can do that. That's no problem.
Okay, perfect. Thank you. Those were all the questions for today. So thank you so much again to our presenters. This was a really wonderful presentation. And I know this will be an excellent resource for everyone to have on our website as well later this week.
Thank you so much for having us.
Thank you.